There is a stark, almost cruel paradox sitting at the very heart of upper limb surgery.
Yeah, there really is.
If you are an orthopedic surgeon, you face it the exact moment you look at the radiograph of a completely shattered elbow.
Absolutely.
Because when we perform a total elbow arthroplasty, we're essentially offering the patient something beautifully elegant.
It's transformative.
Right.
Yeah.
We are taking a joint that has literally been reduced to a bag of bone fragments, and within hours, we provide an operation that delivers almost immediate, sort of miraculous functional recovery.
They wake up and they can move.
Exactly. A patient with a destroyed distal humerus can often move their arm the very next day. They can touch their face, they can feed themselves. It feels like this massive surgical victory.
It does, but then reality sets in.
Yes, the reality you have to confront in theater is that this is arguably the most demanding, unforgiving arthroplasty in all of orthopedics.
Without a doubt.
I mean, it carries a complication profile that completely dwarfs your routine hip and knee replacements. Yeah. We're talking about a deep infection rate that is 3 to 5 times higher.
Which is a terrifying statistic when you're the one holding the scalpel.
Exactly. And on top of that, catastrophic mechanical failures, nerve palsies, and this revision burden that just haunts surgeons for decades.
It is the absolute definition of a high-risk, high-reward intervention. When you are operating on the elbow, you are working within an incredibly hostile, unforgiving anatomical space.
Because there's just no room for error.
Right. Virtually zero margin. If you think about a hip replacement, you have massive margins for error biologically. The elbow affords you nothing.
Just skin and bone, basically.
Right. The soft tissue envelope is practically non-existent. The mechanical leverage forces are astronomical, and the consequences of getting a single step wrong.
Like just slightly mismanaging the triceps.
Exactly. Whether that is your soft tissue handling, your triceps management, or even just your implant rotation, the results are devastating. Not just for the patient's function, but honestly for the surgeon's practice.
It's heavy. So if you're a mid-senior professional, an upper limb surgeon, or an orthopedic trainee listening to this right now, you know exactly what that pressure feels like.
You've felt it in theater.
Definitely. And today on our deep dive, our entire mission is to thoroughly unpack this high-stakes reality. We are going to strip away the textbook summaries and really get into the actual mechanics of why total elbow arthroplasty, or TEA, behaves the way it does.
We're going to look at the physics, the biology, everything.
Spot on. We'll explore why the patients receiving these implants have radically changed, why the physics dictate our surgical approach, the fierce battles over the triceps, and that heavily litigated reality of telling a patient how they must live for the rest of their life once this metal is inside them.
It's a massive shift in their lifestyle.
It really is. And joining me to navigate this immense clinical landscape is an expert guide, a master of upper limb reconstruction. But to really understand where we are today, we have to acknowledge that the patients sitting in your clinic right now, well, they look completely different from the patients who were sitting there 20 years ago.
It's one of the most dramatic epidemiological shifts in modern surgical history, honestly.
The entire demographic just vanished.
Literally vanished. If you walked onto an orthopedic ward in the, say, mid to late 90s, the beds were filled with patients requiring elbow arthroplasty for one overwhelming reason.
Severe rheumatoid arthritis.
Exactly, rheumatoid arthritis. These were patients suffering from profound systemic inflammatory disease. Their immune systems were actively destroying the articular cartilage and that underlying subchondral bone.
But the key there is their activity level, right?
Spot on. Crucially, these patients had very low physical demands. They were profoundly debilitated by polyarticular disease.
Right, they weren't out chopping wood or playing tennis.
No, not at all. They just wanted to be able to brush their hair, or bring a cup of tea to their mouth.
And then the medical management completely pulled the rug out from under the surgical management.
It really did. The advent of biologic disease-modifying antirheumatic drugs.
Biologic BMORDs.
Right, the DMARDs. They fundamentally altered the natural history of rheumatoid arthritis. By medically halting the systemic destruction of the joint at the cellular level, the rheumatologists effectively cured our primary surgical demographic.
Which is amazing for the patients.
Oh, absolutely brilliant for them. But it eliminated the vast majority of our patient base for elective TEA. So today, the most common indication has shifted radically away from systemic inflammatory disease.
And heavily towards acute trauma.
Heavily. Specifically, you are now looking at highly complex comminuted discal humeral fractures in the elderly.
Usually patients well over the age of 75, right?
Yes, over 75, and those presenting with severe post-traumatic arthritis.
Now, if you are listening to this and you take trauma calls, this completely changes the physics of what you are doing. We're no longer putting these implants into frail, low-demand patients with systemic disease.
We're putting them into trauma patients.
Right. These are people who, right up until the exact moment they tripped on a rug or fell down the stairs, they were active.
Very active.
They were driving, gardening, lifting heavy grandchildren. So the biological environment is different, but the mechanical expectation is vastly different.
And that's the crux of the issue.
It is. And to really grasp why TA has become the go-to for these fractures, we have to look at the landmark randomized controlled trial by McKee and his colleagues.
A brilliant piece of work.
Truly brilliant. They took these elderly patients with shattered elbows and directly compared TEA against the traditional gold standard.
Which was open reduction and internal fixation.
ORF?
RIF. And what did they find? Well, that trial is basically the foundational pillar for modern upper limb trauma management now. McKee's team specifically looked at these highly complex, multi-fragmentary fractures.
The ones classified as AO type C3, usually.
Exactly, the C3s, and specifically an osteoporotic bone. And the findings were undeniable. TEA yielded demonstrably superior early functional outcomes.
Superior early function.
All right. The arthroplasty patients achieved a functional range of motion much sooner, and predictably, they had a significantly lower rate of early reoperation compared to the ORF group.
I always think of performing an RIF in this specific demographic as an exercise in sheer futility.
It's incredibly frustrating.
It is.
Yeah.
You have severe osteoporosis combined with severe comminution. It is literally like trying to drive titanium screws into a meringue.
That is the perfect analogy, a meringue.
Right. If you're the surgeon, you can spend 4 hours in theater meticulously piecing these tiny articular fragments back together with locking plates and tiny screws.
Sweating over the fluoroscopy.
Exactly. You take the final image on the screen, and it looks like a beautiful anatomical reduction.
But the physical reality is very different.
Yes. The moment the patient wakes up and begins even passive rehabilitation, the hardware simply cannot hold that fragile bone together. The fixation fails.
It fails because the biomechanics of fracture fixation rely entirely on the pull-out strength of the screws and the friction between the plate and the bone.
And in osteoporotic bone, there is no pull-out strength.
None. In profound osteopenia, the cortical thickness is practically negligible, and the cancellous bone inside is just empty space. Your screw threads have absolutely nothing to bite into.
So it's just metal spinning in a void.
Right. So as the patient moves, the cyclical loading creates this windshield wiper effect with the screws.
Oh, that's a horrible visual.
It is. They toggle, the bone collapses into varus, the hardware fails, and you end up with a stiff, incredibly painful elbow.
And then what?
Well, what happens next is you inevitably have to take them back to theater for a massive salvage arthroplasty anyway.
But now it's infinitely harder.
Exponentially harder, because now you are dealing with scarred tissue, severely compromised blood supply, and even less bone stock because those failed screws have just chewed it all up.
Which is exactly why TEA is such an elegant bypass.
Yeah.
I mean, you don't even care about fracture union anymore.
Not at all.
You simply resect the shattered articular fragments, throw them straight in the bucket, prepare the medullary canals of the humerus and the ulna, cement your stems in place, and instantly restore the fulcrum of the joint.
It's an immediate mechanical fix.
Entirely independent of local bone healing. The patient wakes up with a stable elbow.
Which sounds perfect.
It does. But here is where I want to play devil's advocate and push back on the parameters we currently use in practice.
Okay, let's hear it.
The literature and general clinical consensus draws a very rigid, strict line at age 75 for offering a primary TEA in a trauma setting.
Yes, that's the standard cutoff.
But if you're telling me that the early outcomes for TA are vastly superior, and we can completely avoid the miserable, painful failure of fracture fixation, why are we gatekeeping this based on a birth year?
It's a fair question.
Right. I mean, if a vibrant, active 68-year-old comes into your emergency department with a completely shattered distal humerus, why on earth shouldn't you offer them the reliable early function of an arthroplasty? Why make them suffer through an ORF that you strongly suspect might fail?
It is probably the most common philosophical debate in upper limb trauma right now. But the gatekeeping is there for a very grim biomechanical
The
reason.
long-term survivorship.
Exactly. It comes down to the brutal reality of long-term survivorship. We gatekeep the procedure because while TEA absolutely wins the sprint, it universally loses the marathon.
That's a great way to put it.
A 68-year-old today has a life expectancy that far exceeds the reliable mechanical lifespan of a standard elbow implant.
Because they're going to live another 20 years.
Right. And we are not just talking about the mere passage of time here. We are talking about cyclical loading, the late complication rate for TEA,
You mean the aseptic loosening?
aseptic loosening, profound periprosthetic bone loss, bushing wear, mechanical failure of the hinge itself. It is substantial and it is cumulative.
That is a ticking clock.
A ticking clock. If you implant a primary TEA into an active 68-year-old, you are virtually guaranteeing that they will face a profoundly complex, dangerous revision surgery in their late 70s or early 80s.
When they are physiologically much less equipped to handle a massive operation.
Exactly. And they will be facing that revision at a time when their local bone stock is already destroyed by the primary implant.
Right.
So we draw the line at 75 to ensure, quite bluntly, that the implant outlives the patient, rather than the other way around.
Okay, so if you are the surgeon making that call, you're essentially deciding whether to buy immediate function today at the cost of catastrophic mechanical debt 15 years down the line.
You are managing the timeline of failure. That's your job.
You're managing the timeline of failure.
Oh.
Wow. And if we accept that these implants are subjected to immense mechanical stress, especially now that we're putting them into trauma patients who still want to garden, drive, and lift heavy objects, we have to look at how these devices are actually engineered to survive those forces.
Because the physics of the elbow joint are terrifying.
They really are. I mean, the engineering must accommodate those immense demands, which brings us to the core philosophy of elbow implant design, which is the mechanics of constraint.
Right.
When you are looking at the array of implants available for TEA, you are essentially choosing between two entirely different mechanical philosophies.
Linked implants, which are often called semi-constrained, and unlinked designs.
Let's really interrogate that mechanism. Because historically, the pioneers of elbow arthroplasty tried to solve this with pure, rigid engineering, didn't they?
They did, and it didn't work.
The very first elbow implants were fully constrained. They were literal, fixed metal hinges, and they failed spectacularly.
They failed universally and catastrophically.
Why exactly?
To understand why, you have to look at the physics of a fully constrained hinge. A rigid hinge acts as a pure fulcrum with zero mechanical tolerance. Think about how you use your arm in daily life.
Okay.
When a patient rotates their forearm, or when they apply a varus or valgus stress.
That happens constantly, right? Like turning a stiff doorknob.
Exactly. Turning a doorknob, wiping a kitchen counter, pushing up out of a chair. That rotational torque has to go somewhere. Because the hinge was perfectly rigid, it could not absorb or dissipate any of that kinetic energy.
So it transfers it.
Right. 100% of that rotational force was transmitted directly down the metal stems and concentrated entirely at the interface between the cement mantle and the host bone.
And bone is biological tissue. It absolutely cannot survive that sheer, rigid stress.
No, it's a fundamental mismatch.
Mismatch of Young's modulus, right? You have rigid cobalt chrome and cement transferring massive torque directly into relatively soft osteoporotic cortical bone.
Precisely. The mechanical stress at that interface caused microscopic fractures in the cement. The cement mantle would shatter, the bone would rapidly resorb due to the localized stress and osteolysis, and the implants experienced rapid catastrophic aseptic loosening.
They just pop loose.
They would literally toggle out of the medullary canal within a few short years.
Unbelievable. So the major engineering breakthrough, the thing that made modern TEA actually possible, came from the work of Bernard Morey and Richard Adams at the Mayo Clinic, right?
Yes, the development of the semi-constrained or linked design. The Coonrad-Morey system is the classic historical example, though modern iterations like the Discovery or the Latitude systems utilize the exact same fundamental biomechanical principles.
So what does semi-constrained actually mean for the listener visualizing this implant?
Well, instead of a rigid metal-on-metal hinge, the semi-constrained design incorporates a locking pin that is surrounded by a specialized polyethylene bushing.
A plastic buffer, basically.
Right. And this bushing deliberately allows for about 7 to 10 degrees of slop or mechanical toggle. It allows the joint to deviate slightly into varus and valgus.
You know, it reminds me of the suspension system in a high-performance vehicle.
How so?
Well, if the chassis of a car is completely rigid and welded solid, the entire frame will literally shatter the moment it hits a deep pothole at high speed.
Right, because there's no shock absorption.
Exactly. But if you engineer springs and shock absorbers into the system, that deliberate, calculated give, the underlying structure is preserved because the destructive kinetic force is dissipated over longer duration and transferred to other components.
That is the exact biomechanical goal of the bushing. By allowing that 7 to 10 degrees of toggle, the implant stops acting as a rigid, destructive lever arm.
It shares the load.
Yes. Instead of the rotational stress transferring down the intramedullary stems to the cement bone interface, those forces are absorbed and dissipated by the surrounding soft tissues.
Which soft tissues, specifically?
You are transferring the force to the native collateral ligaments, the joint capsule, and the dynamic muscle envelope of the arm. You are essentially asking the patient's native biology to share the mechanical load with the titanium and cobalt chrome.
Which is a beautiful piece of bioengineering.
It really is.
But it immediately brings up a crucial question about the other option on the table: unlinked implants.
Right.
If we know that linked, semi-constrained implants solve the catastrophic loosening problem by relying on the soft tissues to absorb that toggle,
Yeah.
and we know that unlinked implants rely entirely on perfect ligamentous balancing just to keep the joint from physically dislocating, is there ever a genuine clinical justification for using an unlinked implant today?
It's a very narrow window.
Because they feel effectively obsolete, particularly given that our main demographic is now trauma.
If we are talking strictly about the trauma setting, unlinked implants are practically obsolete.
Because the ligaments are shredded.
Exactly. When a 78-year-old falls and shatters their distal humerus into 5 pieces, the trauma fundamentally destroys the collateral ligaments. The epicondyles, which serve as the attachment points for those ligaments, are often completely avulsed.
So there's no anatomy left to balance.
None. The articular geometry required for an unlinked implant to track correctly is gone. You cannot use an unlinked implant because there is nothing left to hold the joint together.
Right.
However, unlinked implants still maintain a very narrow, highly specific indication in elective practice.
Like primary osteoarthritis.
Yes, primary osteoarthritis, or perhaps a uniquely well-preserved rheumatoid patient where the collateral ligaments are perfectly intact, the bone stock is robust, and the deformity is minimal.
I see.
In those rare cases, an unlinked implant can provide excellent, highly anatomical kinematics, but you are entirely at the mercy of your soft tissue balancing.
It's a high wire act.
It is. If your tensioning is off by just a few millimeters, or if the ulnar component is slightly malrotated, the elbow will dislocate postoperatively. It is incredibly unforgiving.
So for trauma, linked is the only way.
For trauma, the linked, semi-constrained design is the universal standard because it guarantees intrinsic stability regardless of what the ligaments are doing.
But wait, let's follow that logic for a second. That heavy reliance on soft tissues, whether it is to absorb the mechanical stress in a linked implant or to prevent absolute dislocation in an unlinked one, it means the surgery is not just a carpentry exercise.
Far from it.
You can have the most beautifully engineered, perfectly cemented, semi-constrained implant in the world sitting right there on your tray, but if you mishandle the soft tissues to get it into the bone, the entire operation is a failure.
Absolutely.
And if you are the surgeon holding the scalpel, the most heavily debated, frustrating soft tissue structure standing between you and a successful outcome is a triceps.
The triceps is the gatekeeper to the elbow joint.
It really is in the way.
Because the standard, universally accepted approach for a total elbow arthroplasty is posterior. The massive bulk of the triceps muscle and its tendinous insertion sits directly between your scalpel and the distal humerus.
You literally cannot see the joint without dealing with it.
Right. How you manage that extensor mechanism during the surgical exposure often dictates the entire trajectory of the patient's postoperative life.
So if you are visualizing the back of the elbow right now, the triceps is completely blocking the door to the joint. You have to get through it to resect the bone and prepare the canals. So what are the options?
Well, broadly, you have 3 categories.
Do you peel it off? Do you split it straight down the middle? Or do you try to somehow work around the edges? Why is this such a fierce battleground in upper limb surgery?
It is a battleground because triceps insufficiency, where the extensor mechanism fails to function after surgery, is widely considered one of the most debilitating, miserable complications a patient can endure following a TEA.
Because they lose active extension.
Exactly. The elbow relies on gravity for extension in many passive daily tasks, but active, forceful extension against resistance is entirely dependent on the triceps. If you detach the triceps from its insertion on the olecranon to visualize the joint, which is exactly what you do in a traditional reflecting approach, like a Brian Morey or a Tarap approach.
You have to repair it at the end of the case.
You do. You have to suture that tendon back down to the bone. If that repair fails, or if the tendon stretches and becomes attenuated over the first 6 weeks of healing, the extensor mechanism is compromised.
And the functional deficit is massive.
It's life-altering. The patient literally cannot push themselves up out of a chair. They cannot reach up to a high shelf to grab a plate. They cannot push a heavy door open.
Their rehabilitation just stalls completely.
Stalls completely, and they are left with a profound functional deficit that is incredibly difficult to revise.
And think about the biology here. Repairing a tendon back to bone in an elderly osteoporotic trauma patient who has just had their joint replaced is notoriously unreliable.
The tissue quality is just abysmal.
Right. The tissue is poor, the bone is soft, sutures just pull straight through the bone like cheese wire. So naturally, the surgical pendulum is heavily swinging towards triceps-sparing techniques.
Yes, the paratricipital approach is gaining massive popularity.
These are approaches where the extensor mechanism remains firmly attached to the olecranon, and the surgeon creates windows on either side of the tendon to work through.
You're working around it, essentially.
But let me stop you there and push back on the reality of this for most surgeons.
Okay.
If you are a trainee listening to this, or even an upper limb consultant who does not perform a high volume of primary elbows, maybe you do 2 or 3 a year.
Which is very common.
The visibility in a triceps-sparing approach is severely restricted. You are essentially working through a keyhole.
It's very tight.
Is the risk of poor implant positioning, perhaps cementing the ulnar component in severe malrotation because you simply cannot see clearly down the canal? Is that actually worse than the risk of triceps insufficiency from a standard reflecting approach?
That is the absolute crux of the surgical dilemma, and it's a phenomenal point. Triceps-sparing approaches demand exceptional spatial awareness and experience.
Because you're working somewhat blind.
You are leaving the central tendon intact and working through lateral and medial windows. You are blindly reaming and broaching the medullary canals of the humerus and the ulna.
Which is terrifying if you don't do it every week.
If you cannot see your anatomical landmarks clearly, the risk of malpositioning skyrockets. And if you malrotate the ulnar component by even 10 or 15 degrees, the kinematics of the linked hinge are ruined.
It just binds up.
The implant will bind, which leads to rapid premature wear of the polyethylene bushings, particulate debris, and early catastrophic failure of the entire system.
So for a low-volume surgeon?
For a low-volume surgeon, the clinical consensus often dictates prioritizing visualization over tissue preservation.
Right. Peel it so you can see it.
Exactly. It is far better to have a perfectly positioned, perfectly cemented implant with a meticulous, heavily protected triceps repair than a malrotated implant with an intact triceps.
Because a malrotated implant is a guaranteed failure.
A guaranteed failure. However, for high-volume, fellowship-trained arthroplasty surgeons, triceps sparing is rapidly becoming the gold standard.
Because they have the reps to do it safely.
Yes. And removing the biological risk of extensor mechanism failure completely transforms the postoperative recovery. Those patients can begin active extension and load-bearing rehabilitation almost immediately without the constant fear of rupturing a repair.
It is a massive victory to preserve the triceps, and if you can do it safely, it changes the game. But as we know, navigating the triceps is only one hurdle.
Oh, just the first of many.
You can do a flawless triceps-sparing approach,
Yeah.
place the implant perfectly, and still lose the elbow completely.
Please.
We have to confront the reality that TEA is an operation fraught with uniquely high risks. We touched on it at the very beginning, but we need to dive deeply into the complication profile because it is notoriously unforgiving.
It's the infection rate that keeps you awake at night.
That's the glaring, terrifying statistic for any surgeon. We are talking about deep periprosthetic joint infections occurring at a rate 3 to 5 times higher than in primary hip or knee arthroplasty.
The infection data is incredibly sobering. And to understand why, you have to look at the regional anatomy.
It's so different from the lower limb.
Entirely different. When you replace a hip, you are working deep within the body. The implant is buried beneath massive, thick layers of gluteal musculature, the tensor fasciae latae, and substantial adipose tissue.
It's protected.
Right. It has an incredibly robust, highly vascularized biological envelope protecting it from the outside world. The elbow has absolutely none of that.
I always visualize the hip joint as a high-security vault buried deep underground, heavily fortified by muscle.
That's a good way to look at it.
And the elbow, by contrast, is sitting right on the front porch. It is entirely exposed to the elements. You have the epidermis, a microscopic, almost translucent layer of subcutaneous fat, and then you are directly on top of the implant.
That is exactly the reality. The olecranon and the posterior aspect of the elbow are practically subcutaneous. Because there is no thick muscular envelope to provide collateral circulation, the local vascular supply to the skin is comparatively poor.
It's just a tenuous blood supply.
Exactly. And this is where the cascade of disaster begins. If a patient develops even a minor superficial wound breakdown, perhaps the surgical incision takes slightly longer to heal, or there is a millimeter of marginal necrosis at the skin edges due to retractor traction.
There's a tiny bit of necrosis.
That superficial defect often communicates directly with the deep hardware. A minor wound healing issue in a knee arthroplasty is a nuisance that requires some dressings and oral antibiotics.
But in an elbow,
A minor wound healing issue in an elbow arthroplasty is an existential threat to the prosthesis. Once bacteria reach that cobalt chrome and form a biofilm, the implant is infected, and systemic antibiotics are useless against the glycocalyx of that biofilm.
and we compound that inherent anatomical vulnerability by looking at the specific demographic we are operating on.
Right. Their baseline biology is often compromised.
Even though we are doing more trauma cases now, many TEA patients still have a background of rheumatoid arthritis, meaning they have been on immunosuppressive biologics or long-term systemic corticosteroids for decades.
Their skin is like wet tissue paper.
Wet tissue paper, exactly. It has zero healing potential. Add in the frailty, the diabetes, and the poor peripheral circulation of the over 75 trauma demographic, and you have essentially engineered a perfect storm for deep infection.
Which is exactly why meticulous soft tissue handling during the procedure is the single most critical factor in preventing disaster.
More than the bone cuts.
I would argue it is more important than your bone cuts. You cannot use heavy, self-retaining retractors that crush the skin edges. You must preserve thick, full-thickness fasciocutaneous flaps when you elevate the tissues.
No undermining the skin.
You cannot constantly undermine the skin. You must achieve absolute rigorous hemostasis before closure to prevent a postoperative hematoma.
Because a hematoma is just a petri dish.
A hematoma in that subcutaneous space acts as a perfect, nutrient-rich culture medium for bacteria like Staphylococcus epidermidis to thrive. If you do not respect the soft tissues, the elbow will get infected.
Which actually makes me wonder about cross-pollination between surgical specialties here.
What do you mean?
Well, given the absolutely devastating impact of a deep infection in a TEA, which usually results in a two-stage revision, temporary cement spacers, and months of misery for the patient,
It's awful.
should we be looking much closer at what plastic surgery does? Should prophylactic soft tissue flaps or biological augmentation like an Anconius muscle flap become a standard routine part of the primary procedure for high-risk patients?
It's a highly debated, very progressive concept right now.
Because why are we waiting to use these vascularized flaps in a salvage situation when the joint is already infected and we are desperate?
Well, the Anconius flap is a fantastic biological tool. It takes a small local muscle and rotates it to bring robust, highly vascularized tissue directly over the posterior aspect of the elbow, literally burying the implant.
Which sounds like exactly what we need.
It is. Some highly specialized upper limb centers do advocate for prophylactic local flaps in severely compromised primary cases. For instance, a rheumatoid patient on heavy steroids with paper-thin, translucent skin.
So why isn't everyone doing it?
Because there's a trade-off. Mobilizing flaps adds significant surgical time, it creates additional morbidity and potential hematoma space at the donor site, and it alters the local anatomy further.
I see.
The general consensus among most arthroplasty surgeons remains that perfect atraumatic surgical technique and attention-free wound closure are sufficient for primary cases.
So handle the tissues well and you won't need the flap.
That's the prevailing thought. But the clinical threshold to involve plastic surgery for soft tissue coverage at the slightest hint of wound trouble, even on day 3 or 4 post-op, must be incredibly low. You cannot watch and wait with an elbow wound.
So you basically have to be paranoid about the skin. But the soft tissue isn't just about infection. The other major anatomical structure at severe risk during this approach is the ulnar nerve.
You can't avoid it.
You cannot perform a posterior approach to the elbow without intimately interacting with the ulnar nerve. It sits right there in the cubital tunnel, wrapping behind the medial epicondyle, exactly where we need to resect bone and place cement.
Ulnar neuropathy is a major, highly frequent complication of TEA. The nerve is exquisitely sensitive to traction, to direct compression from retractors, and to devascularization.
So what's the debate in theater once you found it?
The debate, once you have identified the nerve, is always how to handle it. Do you simply decompress the nerve in situ, meaning you release the overlying fascia and free it up, but leave it sitting in its natural groove?
Or do you move it?
Right. Do you perform a formal anterior transposition, dissecting it completely out of its bed and moving it entirely out of the surgical field, placing it anterior to the medial epicondyle?
If you are looking at it purely mechanically, transposition seems intuitively safer.
It gets it out of harm's way.
Right. You get the nerve completely out of the way of your oscillating saws, your retractors, and the massive exothermic heat generated by the curing cement.
Yes,
But by moving it, you also strip its entire local blood supply, don't you?
you do, and that is the biological cost of transposition. The ulnar nerve relies on a delicate vascular luge, including the inferior ulnar collateral artery and the posterior ulnar recurrent artery.
Which you have to cut to move it.
Exactly. Extensive mobilization and transposition tear these tiny vessels, which can lead directly to ischemic neuropathy. The nerve essentially starves.
Oh, wow.
Furthermore, if the transposition is not perfect, you can create new points of compression or kinking.
So what does the evidence actually say?
Most current evidence suggests that if the nerve does not spontaneously subluxate over the epicondyle when the elbow is flexed and it sits comfortably away from the hardware, an in situ decompression is preferred.
Just leave it alone.
You protect it during the case, but you leave it where it belongs. You only transpose the nerve if it is highly unstable, or if the specific design of the ulnar component's flange places the nerve in direct jeopardy.
It is the constant, delicate balancing act. You are balancing triceps preservation against visualization, skin tension against exposure, and nerve safety against devascularization.
It's surgical plate spinning.
It really is. And if any of these balances tip the wrong way, if an infection sets in, or if the ulnar component eventually loosens over time due to stress, the surgeon is forced into the highly complex, frankly terrifying territory of revision surgery.
The revision burden is immense.
This brings us to the reality of surviving the long term and the massive burden of paraprosthetic fractures and severe bone stock depletion.
The long-term survivorship data for TA requires very careful, nuanced interpretation. We often look at the extensive work of Sancho Sotelo and his team regarding the survivorship of linked TEA.
And the National Joint Registry data as well.
Yes, and we corroborate that with data from the NJR and the BESS and BOA guidelines here in the UK. What the data shows us is that at 5 years, survivorship is generally quite good, often exceeding 90%.
So at 5 years, patients are happy.
Very happy. But when you look at year 10, and certainly when you stretch out to year 15, the survival curves begin to drop sharply. The implants begin to fail at an accelerating rate.
And the primary challenge when a TA fails 15 years down the line isn't just swapping out a worn hinge.
No, it's not a quick fix.
It is not like changing the brake pads on a car. The true nightmare is the profound, catastrophic depletion of the local bone stock.
Exactly. When we implant a primary TA, especially a link design like the Coonrad-Mori, we use long, cemented intramedullary stems that travel deep into the diaphysis of both the humerus and the ulna. Over 15 years, the biomechanical stress of that rigid implant shielding the native bone from normal loads, a phenomenon known as stress shielding, combined with the normal physiological aging process, severely thins the cortices of the bone.
The bone just melts away because it's not being stressed.
Right. Furthermore, as the polyethylene bushing inevitably wears down, it sheds microscopic plastic particles. Macrophages consume these particles, trigger a massive inflammatory cascade, and literally eat away the surrounding bone in a process called osteolysis.
So the bone is being eaten from the inside out.
Exactly. So when that long cemented stem eventually loosens, or if a late infection requires us to remove it, extracting a 6-inch metal rod encased in rock-hard cement from an ulna that now has the structural integrity of an eggshell is, well, it's a surgical nightmare.
Just visualizing that extraction makes me tense. The risk of exploding the entire diaphysis while trying to get that cement mantle out is astronomical.
It is a highly treacherous procedure. You cannot simply pull it out. Surgeons often have to perform controlled osteotomies.
Literally splitting the bone open.
Yes, literally using a high-speed burr to cut physical windows into the cortical bone along the length of the arm just to access and fragment the old cement mantle with ultrasonic tools.
Wow.
By the time you have safely cleared the canal and removed the old hardware, you are left with a massive segmental bone defect. There is often absolutely nothing left to hold a new, standard revision implant.
Which means you are turning to incredibly complex, heroic salvage options at that point.
You really are.
We are talking about massive impaction bone grafting or using allograft prosthetic composites, where you literally cement the new revision implant into a cadaveric bone segment on the back table,
Right.
and then use heavy locking plates and cables to attach that entire construct onto whatever is left of the patient's native bone.
It's major reconstruction.
Or increasingly, we are relying on custom 3D printed porous titanium flanges designed from CT scans to bridge the massive defects. It is phenomenal engineering, but the functional outcomes, the range of motion, and the complication rates are never, ever the same as the primary procedure.
Never. And that profound bone loss, that eggshell cortex, leads directly to the other major long-term disaster we see in the emergency department, the periprosthetic fracture.
Oh, those are awful.
Because the bone surrounding and just beyond the tip of the cemented stems is so structurally compromised, it acts as a massive stress raiser.
A breaking point.
A breaking point. A very low-energy mechanism, something as simple as a patient pushing themselves up from a deep armchair too forcefully, or slipping and throwing their arm against a wall to catch their weight.
Just normal daily life thing.
Exactly. Can snap the humerus or the ulna right at the tip of the cemented stem.
I want to establish a real-world clinical framework here for the listeners. Imagine you are on call. You are presented with an 82-year-old patient who has sustained a periprosthetic humerus fracture just above their TA stem.
Okay.
Let's say it is a spiral fracture at the diaphyseal junction. How do you decide in that exact moment if this is a fracture problem requiring locking plates and circlage cables, or if this is an arthroplasty problem requiring a massive open-the-canal revision?
The entire treatment algorithm hinges on one single critical factor.
Which is?
The status of the implant-bone interface. Is the stem still rigidly fixed, or is it loose?
Okay, how do you determine that?
If the radiographic evidence looking for radiolucent lines around the cement and the clinical history suggests the stem is perfectly fixed within that distal bone fragment, then you treat it as a trauma problem.
So you played it.
You perform an ORIF, you utilize long locking plates, circlage cables, and perhaps cortical strut allografts to bypass the fracture and span the full length of the bone to share the load. You absolutely do not disrupt a well-fixed stem.
Leave the stem alone if it's tight.
Exactly. However, if there is any evidence of radiolucency around the cement mantle, or if the stem has toggled or subsided within the canal, the fracture is essentially just a symptom of the loose implant.
The loosen that caused the break.
Right. In that scenario, plating the bone is futile. The loose implant will continue to act as a destructive, moving lever arm inside the canal, and your plate will fail.
So what's the move?
You must revise the joint, extracting the loose component and bypassing the fracture with a longer, specialized revision stem that achieves stability and healthy bone further up the shaft.
To avoid these catastrophic late-stage failures, to prevent the aseptic loosening, the osteolysis, and the periprosthetic fractures, surgeons rely heavily on post-operative protocols to manage how the patient lives their life.
It's all about load management.
And this brings us to what is easily the most contentious, heavily debated, and deeply frustrating post-operative reality in upper limb surgery: the great activity restriction debate.
Every single patient who undergoes a total elbow arthroplasty must be counseled extensively, repeatedly, and aggressively on permanent activity restrictions.
And the big one is the 5-pound rule.
The most famous, or perhaps infamous, of these restrictions is the strict 5-pound lift limit. We sit these patients down and tell them they can never lift anything heavier than a bag of sugar or a standard kettle with that operative arm for the rest of their natural lives.
But let us truly interrogate the origins of this 5-pound rule. If you look at the literature, is this limit based on rigorous, peer-reviewed biomechanical evidence?
It's really not.
Did someone put these implants into a cyclical stress simulator, apply exactly 5.1 pounds of force, and observe structural failure of the cement mantle? Or is this essentially historical anecdotal tradition passed down from generation to generation of anxious surgeons simply trying to protect the vulnerable implant-bone interface from the leverage forces of the forearm.
It is entirely the latter. The 5-pound rule is not a precise biological or metallurgical threshold. It is an arbitrary, pragmatic heuristic designed to mitigate the massive lever arm of the upper limb.
Because it's a long lever.
You have to think about the physics equation. Moment equals force multiplied by distance. When a patient holds a 5-pound weight in their hand, the distance from their hand to the elbow joint, the length of the forearm, which is roughly 30 centimeters, acts as a long lever.
So 5 pounds at the hand is much more at the joint.
Exactly. The actual moment of force generated at the hinge and transmitted deep into the cement mantle in the humerus is exponentially higher than 5 pounds.
And the muscles add to that force, right?
That is before you even factor in the massive force of the triceps and biceps co-contracting to stabilize that load, which multiplies the joint reaction force even further.
Wow.
The rule exists because the long-term survivorship data unequivocally shows that high-demand activities, repetitive loading, and heavy lifting directly cause premature aseptic loosening.
The medical legal reality surrounding this is fascinating and terrifying.
It's a huge source of litigation.
Right. If you read the clinical guidelines, they emphasize that failure to counsel a patient extensively on these exact restrictions is one of the most common pitfalls leading to successful litigation in upper limb arthroplasty.
Without a doubt.
If a patient feels great at year 2, goes back to playing golf or chopping wood, and their implant catastrophically fails at year 3, the very first thing the legal team will request is the clinical notes.
They want the proof.
They are looking for documented proof that the surgeon explicitly told the patient not to do those things.
Precisely. Patient selection and patient education are completely inseparable from the surgical technique itself. They are part of the operation.
It's not just cutting and sewing?
No. If you think about a hip replacement, the ultimate goal is to let the patient forget they ever had surgery. They walk, they run, they hike, and the prosthetic joint functions silently in the background of their life.
But an elbow replacement is different.
An elbow replacement is the exact opposite. It demands that the patient remembers it every single time they interact with the physical world.
That's a huge cognitive load.
It is. Every time they reach to pick up a kettle, every time they try to open a heavy oak door, every time they pull a wet load of laundry out of a washing machine, they have to consciously stop, assess the weight, and self-limit.
It is essentially a psychological contract we are forcing them into. We are giving them a beautiful, pain-free joint that moves smoothly, but we're attaching a permanent, lifelong alarm system to it.
That's a very good way of framing it.
You can look at it, you can move it, you can feed yourself with it, but you cannot truly load it. But let me play devil's advocate and push back on this, because I see this in clinic all the time. Are we being far too paternalistic with this strict 5-pound rule?
In what sense?
Think about the physics of everyday life.
Yeah.
Pushing yourself up from a low chair, pushing open a heavy commercial door, or catching your balance against a wall easily exerts forces that far exceed 5 pounds across the elbow.
Oh, certainly.
Standard daily tasks routinely break this rule. Are we setting a strictly enforced rule that we know deep down patients will inevitably break just by living, simply to legally protect ourselves when the implant eventually fails?
There is undeniably an element of defensive medicine embedded in the 5-pound rule. We are not naive. We know patients will occasionally break it. Humans are not perfectly compliant, programmed machines.
No, they're not.
However, setting the baseline expectation at 5 pounds ensures that the patient actively avoids repetitive, cyclic, heavy loading. If we told a patient 10 pounds, human nature dictates they would push it to 20.
Right, they'll always push the boundary.
By setting a very low, easily understandable, universally relatable threshold, absolutely nothing heavier than a kettle, we limit the aggregate mechanical stress placed on the prosthesis over a decade.
So it's about the cumulative wear and tear.
Exactly. It is about maximizing the lifespan of that fragile cement mantle. It might feel paternalistic to the patient, but it is deeply biologically protective of their long-term anatomy.
And it forces a massive shift in their lifestyle, which brings us perfectly full circle to why we restrict this procedure primarily to the elderly trauma population or the low-demand rheumatoid patient.
You can't put this in a young laborer.
You simply cannot ask a 50-year-old manual laborer or 55-year-old nurse who has to lift patients on a ward to accept a 5-pound lifelong limit. It ruins their livelihood.
You cannot. And that is why, despite the elegant mechanics of the operation and the immediate gratification of restoring movement, it remains a heavily guarded, strictly indicated procedure.
The stakes are just too high.
The stakes at every single stage. From selecting the right patient, to the anatomical exposure, to meticulous infection control, to lifelong behavioral counseling, they are exceptionally high.
This has been a phenomenal, incredibly dense breakdown of a procedure that truly tests every skill a surgeon possesses.
It's been a great discussion.
If you are listening to this on your commute or between cases, let us distill this vast landscape into 4 memorable clinical pearls you can actually take into your practice.
Excellent idea.
First, TEA in the over 75 trauma patient offers superb early functional recovery and avoids the absolute nightmare of failed fracture fixation in osteoporotic bone. But you are trading that early victory for high long-term risks compared to RF. You're managing the timeline of failure.
Spot on.
Second, your management of the triceps is the make-or-break moment for the patient's rehabilitation. Whether you have the skill to spare it or you meticulously repair it after reflecting it, the extensor mechanism must be respected at all costs.
It's the gatekeeper.
Third, the subcutaneous exposed nature of the elbow makes meticulous, atraumatic soft tissue handling absolutely non-negotiable. You are fighting a 3 to 5 times higher infection rate from the very second your scalpel touches the skin.
Respect the tissues.
And finally, comprehensive, heavily documented patient counseling regarding lifelong activity limits, specifically the 5-pound rule, is an absolute medical, legal, and ethical necessity.
Those are the foundational pillars of elbow arthroplasty. Mastering the bone cuts, understanding the mechanics of constraint, and perfecting your cementing technique is really only half the battle.
Right.
Mastering the soft tissues and managing the patient's long-term expectations dictates the true, lasting success of the arthroplasty.
If you found this deep dive into the high-stakes world of elbow arthroplasty valuable for your clinical practice, please take a second to rate and share the deep dive with your colleagues and trainees. It truly helps us keep bringing you these high-level, unfiltered clinical discussions.
It makes a big difference.
I want to leave everyone listening with a final, forward-looking thought. We have spent this entire session discussing the severe mechanical limitations of current cemented stems, the terrifying, constant threat of the soft tissue envelope, and the inevitable engineering failures that lead to massive bone loss and complex revision.
A lot of hurdles.
Given all of this, will the next great leap in TEA actually come from even more complex biomechanical hinge designs and highly porous metal coatings?
Or maybe something else entirely.
Exactly. Or will it come from biological innovations? Perhaps radical advancements in tissue engineering that allow us to regenerate a robust soft tissue envelope and restore native bone stock, effectively making these heavy metal hinges completely obsolete.
It's a fascinating prospect.
Have we simply hit an engineering ceiling in orthopedics that only biology can break? Something to seriously consider the next time you are looking at a shattered distal humerus on the fluoroscopy screen. Until next time, keep diving deep.